This lecture recording was intended for qualified cleft surgeons and trainees. The Anatomic Subunit Approximation approach to primary unilateral cleft lip repair. Our surgical objectives are based on the twist deformity of the nose, in which the uncoupled premaxillary growth results in deviation of the columellar base away from the midline. The non-cleftalar base is driven lateral, and the cleftalar base is left behind posteriorly. So how to balance things? We need to centralize the columella, advance the non-cleftalar base medially, and advance the cleftalar base anteriorly. And these movements are fundamental to understanding how we're going to correct the deformity. Today we're going to talk mostly about surgical design, which is effectively the plan. And that is just one small component of the repair. There's analysis, there's wide release, there's component reconstruction of lip and nose elements, but for today we're going to really focus on the plan. As far as repairs goes, there are a number of repairs that have been described: Le Mesurier, Tennyson-Randall, Moeller, and Fisher. And each one of these produces a distinctive pattern of closure along the lip. And while a lot of surgeons spend time debating which one more closely approximates the contours of the philtral column, what's probably even more important than that is how these repair styles help the surgeon. For example, if you take a Le Mesurier repair in which the pattern of scar is actually really unfavorable, if you look at his original description and results, they're actually pretty good. And that's because nice, favorable three-dimensional form has been restored to the nose and the lip. And when that happens, the pattern of the scar matters much less. And so I think it's important to think of these repairs in this manner. The Tennyson-Randall is a very simple geometric design. The Moeller takes a cut-as-you-go approach, and the Fisher has more of a measure twice, cut once flavor to it. Now, as far as that repair goes, although it can help with all of the extra landmarks, there are a lot of landmarks and it can be quite intimidating. And so we simplified the approach, recognizing that each of the landmarks is an anthropometric landmark that a lot of surgeons already understand or new surgeons need to study. I'll talk about some modifications to the original description, including alar insertion point, the nose-lip creases, and defining the so-called arbitrary point. We've also further illustrated the different subunits of the lip and the nose, really ensuring that we recognize the cutaneous roll has a thickness to it, and the philtral column is not simply just a straight line, but it's got a medial and a lateral edge to it. And so that's been updated in both definition as well as in the figure version of the repair itself. And so let's get started. We identify a landmark at the center of the columella at the nose-lip crease or junction. We identify the top of the philtral column along that junction as well. And it's important to note that that's medial to the medial edge of the philtral column. Using those 2 points, we can simply reflect the same distance onto the cleft side where things are less well defined and harder to identify. We find the bottom of the cupid's bow and the top on the one side. And this happens to be, again, medial to the philtral column, and it also is the transition from the straight part of cupid's bow to the gently convex outward bowing portion highlighted in yellow. With those 2 landmarks, we can simply reflect over to the cleft side, where the cupid's bow peak is much more flat rather than having a true peak to it. We identify landmarks that are corresponding above the cutaneous roll, as well as along the wet-dry junction of vermilion and mucosa, the so-called red line. We then find the 2 points along the ala on the non-cleft side. There's the subalare, which is the lowest point on the ala, and there's the alar insertion point, which, if you follow the rim of the nose and find where it intersects with the crease of the sill, that's where the alar insertion point is. We then go to the cleft side and identify the same landmarks. Now, what you'll notice here is that the configuration of the landmarks looks asymmetric. And it looks asymmetric because those landmarks are identified with the lip and the nose in their corrected manner. The columella is centralized and the cleft alar base has been brought anteriorly. And so when we let go of the lip and the nose, the cleft widens, the lip splays, and the nose collapses, and then those landmarks again assume their asymmetric configuration. There is a crease at the base of the nose between the lip and the nose, especially if you press down on the nose, and that crease continues into the nose along the edge of the medial foot plates. Similarly, along the alar creases, if you push the nose down, you can see those creases a little bit better. There are creases that run into the nose and intersect that nasolabial crease from the medial side. Where those two creases intersect is what we call the intersection point X. And that's helpful because we can measure off the pre-existing landmarks to identify the corresponding landmarks on the cleft side. So these are equidistant to the landmarks along the nasolabial crease on the medial side. And on the lateral side, again reflecting from the non-cleft side to the cleft side, we have the same distance from the alar base landmarks to the new point of closure along the nasal floor. And so when we bring these 2 points together, it should produce the nose that we want. From here, it's a simple matter of connecting the dots. Here's the philtral column, the matching non-cleft side philtral column. Here's the incision across the lip, as well as along the nasal sill. And then there are releasing incisions above the cutaneous roll, as well as along the wet-dry junction. We then need to move to the lateral side. We need to find a point along the lateral lip that is going to come together with the medial lip, reproducing the shape and form of the Cupid's bow on the non-cleft side. I've highlighted that a little bit in yellow. This is the Nordhoff point. So if you follow the red line, the junction of wet and dry lip, there tends to be a site where the red line starts to converge with the vermilion border. And this is known as Nordhoff point. Medial to that point, the quality of the cutaneous roll diminishes. Lateral to that point, it's good quality and is similar to the medial lip on the other side of the cleft. So we identify corresponding landmarks above the cutaneous roll, as well as along the red line, the wet-dry junction. And what's interesting is that if you look at the height of the vermilion at Nordhoff point and compare it to the height at the non-cleft Cupid's bow peak, those heights are very similar. And so you can take the deficient vermilion height on the medial side of the cleft and transpose it to the vermilion along Nordhoff point. Whatever remains then becomes the triangle that you use to augment the medial lip. It's here that we stop and take a little pause. We have two fixed points that define the available height along the lateral lip element. And so we need to design lateral lip incisions that match the medial lip incisions, but also augment the medial lip appropriately. A is the height of the philtral column on the non-cleft side. B is the height of the philtral column on the cleft side. And I'll explain a little bit further later, but that height B is usually measured with gentle downward traction on the lip. C is the base width of the triangle that's needed to augment the medial lip height. And the 1 millimeter correction is due to the Rose-Thompson effect. When you excise a diamond and close it as a straight line, the lip height elongates. Now, the configuration of this lateral lip design is along a variable lateral lip height. And so that lateral lip height could be intermediate, and the configuration is like this. Or it could be very short, and the configuration is like this, where the edge of the triangle is collinear with the philtral height, B. Or if there's excess or tall lateral lip height, we may actually have to excise a little wedge in order to equalize and correct the lip heights. And so I think of it this way. We have three components I've highlighted in black, red, and green. And between each of these components, there's a little hinge, similar to one of these really old articulating rulers. And so through those hinges, you can close things down if things are short, or you can widen them out if things are tall. So it's at this point that I'll generally take 3 calipers and set them along the lateral lip elements and see where everything fits in and fits together. And so an alternate way of doing it is to draw arcs from the point of closure on the lateral side of the sill that has a length of S, the corresponding length of incision along the medial lip. On the lower dot is an arc that's drawn with the base width C, which is the triangle that's going to augment the medial lip height. Now where those two arcs and the philtral height B fits in between the two is how we designed our lateral lip incision. We have the limb that runs up to the nasal sill at the lateral point of nasal floor closure. And then on the lower end, we place an equilateral triangle. This is the markings at completion. This is what it looks like in real life and following closure and repair. In terms of executing the repair, there are checkpoints and adjustments. The progression is always from the medial side first. The medial lip incision is made, and then the muscle is dissected, releasing the muscle from the base of the columella. When you do this, the entire prolabium drops down, and that actually can help level the Cupid's bow. And so it's at this point where it's important to check and verify whether you actually need the releasing incision above the cutaneous roll. So checkpoint 1, you use an instrument or something to manually centralize the columella, and then another instrument to gently pull the lip down and see if the Cupid's bow will level out on its own. If the incision isn't needed, then you can adjust. You can change the markings at this point in time. If it is needed, then go ahead and make that incision. Once that incision is made, again, by manually correcting the deformity, you use an instrument to centralize the columella and another instrument to gently pull the lip down, thereby leveling out Cupid's bow. You'll then open up a small defect above the cutaneous roll. That's the extra tissue that's needed in order to balance things. So you can measure the size of that defect. You can also measure what's being marked on the lateral side of the lip and verify that what you're about to incise is going to be what you need to meet the medial lip incisions as well as to augment the medial lip incisions. The repair then progresses onto the lateral side with all the releases so that eventually you get to this point where everything's loose. You can bring the lip and the nose together and you can do your final checkpoint, checkpoint 3, where you can verify if the points that are designed along the sill have been the correct points. If they aren't, then things can be adjusted so that the nose looks just right and the balance of the lip and nose can be achieved. In terms of muscle under the surface, this is what's happening. On the medial side of the cleft, the muscle is released from the base of the columella. It opens up a dead space underneath the columella. On the lateral side, it produces an empty triangle devoid of muscle, lateral to the nasal ala. And then when the muscle's being inset to balance things, you should see that the columella gets dragged over towards the cleft, and so that it is in its balanced, centralized position. Meanwhile, the alar base on the cleft side is being supported anteriorly. This is all a very three-dimensional muscle repair, and as the muscle repair progresses from cranial to caudal, it's important to maintain the three-dimensional shape of the orbicularis muscle. It's got a J shape, similar to the shape of the country Italy, kind of like a boot. It's got a tip and it's got a heel. And getting the heel and the tip of the boot or the J shape to align on one side to another, I think can help to produce a natural pout to the lip, as well as it helps to get all the surface landmarks lined up so then the skin closure is easy. In terms of the nose, through the medial lip incision, a caudal septal repositioning can be performed. On the lateral side, an upper buccal sulcus incision if it's needed in order to mobilize a lip, and then a dissection in a supraperiosteal plane on the anterior surface of the maxilla. If needed, an incision through the periosteum along the piriform aperture is made, and then dissection along the lateral nasal wall with an incision along the cleft margin in yellow and a releasing incision in green that ascends up to the base of the inferior turbinate. With that, the entirety of the lateral nasal wall can be mobilized en bloc as the cleft alar base is being advanced anteriorly. So intraoperatively, with correction of septum, sidewall, and floor only, there's profound changes in the shape of the nose, with the final alteration produced with inset of muscle and skin. On frontal view, pre-op, then septum, sidewall, and floor only, with final change with muscle and skin inset. So what I showed you so far is a kid with a cleft that sits along the spectrum over here. It's a complete cleft with seminar band. If we move to this end of the spectrum, we have a more severe cleft. Again, we identify landmarks at the base of the nose, with the intersection on the non-cleft side defining how we figure out where these 2 points of closure along the nasal sill on the cleft side ought to be. We use the creases along the base of the columella as well as the base of the ala in order to find where those landmarks belong, and then we just simply measure off the corresponding distances from the non-cleft side so that when we bring those 2 points together, it should produce the nose we want. And ultimately, this is the test. When we bring those 2 points together, are we happy with how things look? Again, here's our 2 points of nasal closure. We identify our Cupid's bow landmarks as well as our Nordhoff point, the corresponding landmarks above the cutaneous roll as well as along the wet-dry junction, and the triangle to augment the vermilion height on the medial side. Simple matter of connecting the dots. And then we arrive again at that spot where we have two fixed points on the lateral lip element that define the available lateral lip height. A minus B minus 1 millimeter is C. We have a very short lip height, so we're going to need to scrunch everything together. And if we take that articulating ruler concept, then we're going to need to do this. The filtral height needs to be coincident with the edge of the triangle on one side. We can draw arcs and find where the filtral height fits in between the two. And then draw in our triangle and our sill portion of the incisions. Here's the markings in real life and at the completion of surgery. Now, if we move out the other direction along the spectrum of presentation, we can look at a child with an incomplete cleft lip. Again, we identify the points along the nasal sill, as well as the Cupid's bow and Nordhoff point. This helps to define the 2 points of closure along the nasal sill that we need to bring together to produce the nose that we want. Here, however, we can measure things further. We can use Hagar dilators, which have diameters written on them, to measure the size of the nostrils. We know that pi times diameter is the circumference of the circle. Pi is essentially 3, and so the difference in nostril circumference is going to be the difference in diameters multiplied by 3. Now that gives us a little bit of a guide of how much of the nasal floor we ought to excise, but what's important is that we don't excise too much, and what's important is that we don't produce a micronostril. So we want to keep the excision less than what we calculate. And so there's that excision. Again, we arrive where we now have 2 fixed points. These 2 fixed points define the available lateral lip height, and you can see that it's quite tall here. A minus B minus 1 millimeter is C. And this is what we don't want to do. So if we again draw these arcs and find where the filtral height fits in between, we would end up with a design like this. And the problem here is that the angle between elements on the medial lip design are quite acute, whereas the angle between limb elements on the lateral lip are quite obtuse. So after incising, we're going to have a hard time putting things together and having them sit nicely. And so this is what we do. We drop this limb down, we extend this limb up, and whatever remaining height is there, we excise so that we eventually arrive at the lateral point of closure along the nasal sill. And this way, we keep the angle between the limbs on the medial and the lateral side fairly similar. Here are the lip markings in real life, and then at the completion of surgery. And what you'll notice is that the triangular excision sits nicely along the base of the ala. It hides nicely there, and that's because the design is along the crease along the base of the ala, just beyond the muscle bulge. In an area where if you're performing rotation advancement or a cut as you go approach, you might be excising that a lot at the time of inset. How do you know when to excise a triangle? Well, if you look at the vertical position of Nordhoff point relative to the Cupid's bow peak on the non-cleft side, it's actually quite a bit lower. We can measure the lateral lip height and determine whether there's an excess there or not. And ultimately, what's helpful, or what's important, I think, is that the angle between the limbs on the medial side and the lateral side are matching. Let's go further along the spectrum. So here's a more minor incomplete cleft. There's some nose asymmetry. A minus B minus 1 millimeter is 1, so we do the full repair. If we go further along the spectrum, we have an even more minor incomplete cleft. There is nose asymmetry. A minus B minus 1 millimeter is 0, so we do the full repair, but there's no releasing incision necessary and no triangle necessary. And then if we go even further along the spectrum, here's a microform cleft. There is nose symmetry, so we don't need to proceed with excision up to the nasal sill. And the repair is similar to that described by Mulliken, the double unilimb Z-plasty, but we arrive at that by placing all our landmarks, it's a system really, and when we place all those landmarks, we determine that there is no excision necessary because on the cleft side, those 2 points of closure are coincident. And so here we can taper things off. And so that's the spectrum of presentation. There are some important details and differences to other repairs. The first is that with the anatomic subunit approach, the alar base and the upper lip are dealt with as a single unit, whereas with other repairs, they may be separated into 2 different components. The second is that the Nordhoff point is considered a fixed anatomic landmark, and there is no compromise in identifying its position, whereas with other repairs, that point may be moved further lateral to Nordhoff point. And so in many ways, when people talk about moving Nordhoff point lateral, they're actually moving their lateral point of closure along the lip further lateral rather than Nordhoff itself. Nordhoff's point is an anatomic landmark. How do we keep the triangular flaps small? Well, we have the Rose-Thompson effect. And the more acute the angle between limbs, the more elongation we get with release. And this will tend to be the case with more severe clefts where that angle is steeper. Now, another important piece is that A is measured at rest and B is measured with downward traction to unfurl the lip. In addition, we've also identified that through lip repair, the non-cleft filtral height shortens. And this is likely due to the tension that's placed on that side of the lip with the horizontal inset of muscle and skin. And so with the measurement of A, it perhaps should be measured with some anticipated shortening. And these are very critical when measuring A and B to determine the base width C. Now there are some checkpoints along the way. Checkpoint 1, we start with the medial lip. We release the muscle, and then we determine if the releasing incision above the cutaneous roll is necessary. If it is, we can go ahead with the incision, and then we drop the cubis bow down. Once it's dropped down, we can then measure the vertical deficit that needs to be filled from the lateral side, and then go ahead and see if what we've already marked out on the lateral side is correct. If it is, then we can go ahead with the incision. If it isn't, then we can go ahead and adjust it before we make that incision. We go ahead with the lateral side, and with everything released and mobilized, we can again verify whether those 2 points of closure along the nasal sill have been correctly identified, and if they haven't, we still have an opportunity to adjust things. So I've talked a lot about the surgical plan, and again, there's a lot more to cleft lip repair than that, but hopefully that provides us with a good baseline and a start, because that plan really is critical.
Thank you for your attention. Here are some references in case they help.